Welcome back to PT Meal Podcast, a buffet of play, therapies, movement, exercises, activities, and leisure, all packed in a hearty conversation of physical therapy profession and practice with a Filipino flavor. I am Johann de your host. Welcome again to the banquet. Again, for those who are here for the first time, this podcast is available in your favorite podcast streaming apps, Spotify, Apple Podcasts, Google Podcasts, Anchor, iHeartRadio, Amazon Music, and many more. Let me know if you're using a podcast app that is not there, so that I can do something about that. You can also watch most of the full episodes and live streams on YouTube if you want to stay updated on fresh episodes, interview snippets, research abstracts, or infographics. Follow us in social media in Facebook, Instagram, LinkedIn, and Twitter. Check out also our merch in Etsy. Search for PT Meal Shop, one word, at etsy.com, and help us go buy our merch, and that would really help the podcast to help me sustain it. It's quite expensive to have a podcast, actually, just one person. So, and if you also want to sponsor a podcast, the podcast, please reach out to me. And any comments and suggestions, you can email me at ptmealpodcast@gmail.com. You can also send me a DM or private message in my social media. So all the links and content are available in the website, ptmealpodcast.com. All right, so let's go. So for today's episode, I don't have a guest. This is one of those solo episodes that I usually do from time to time. So today, I am going to talk about a setting I currently work in. The setting I currently work in, it's a forensic psychiatric hospital. So this episode is not related to my work, but it's a part of my passion in spreading awareness about the different areas of practice in our profession, and at the same time, introduce the setting as an opportunity for research, collaboration, if there are researchers who want to collaborate with me, and ignite interest in other physical therapists that we can also work, or we also have some work in this type of setting. Okay, so let's start. So I organized this episode like an FAQ, so frequently asked questions. Whenever a colleague find out that I work in a forensic psychiatric hospital, these are the questions that they usually ask me, and I've kind of gotten good in how I answer them. For this episode, that is what I'm gonna do: share with you those questions and the answers I usually give them. Okay, first question is, why is it called forensic? Okay, when we hear about forensics, we remember, or we think about the TV shows like CSI, forensic investigations, DNA, crime, stuff like that. But if we look at the definition in the dictionary, forensic is anything relating to courts of law. And if we go to what forensic psychiatry is, it's a clinical subspecialty that is concerned with helping people who have mental disorder, who present a risk or a significant risk, and may have been in trouble with the law. So those who have pending cases, who have been tried or not have been tried because of their mental disorder. So in the hospital, what the patients are usually there for is, or what the doctors are there for, is to determine if the patients are fit to be released in the community, if they're fit to be released in a supervised home, or if they're supposed to go back to the prison, or if they're competent to stand trial. So I could think of two types of settings in this forensic bubble, which is the psychiatric hospital and the correctional, right? So in both settings, there there are physical therapists. So there are physical therapists in prison. So, but what we're going to focus on here is the forensic psychiatric hospital where I'm working at. Right. So next question I usually get asked is, how many of the patients you see have psychiatric diagnosis? Well, the simple answer is all of them. Okay, so they won't be there if they don't have any psychiatric diagnosis. They might be sent to a different hospital if they need, medical attention, but primarily they're in the psychiatric hospital because they are in need of psychiatric help. Most of the common conditions that I usually encounter are schizophrenia, schizoaffective disorders, post-traumatic stress disorders, bipolar disorders, neurocognitive disorders, anxiety disorders, disruptive behaviors, among others. So they do present with, some of them do present with psychotic symptoms. Some of them do present with maladaptive behaviors. And for most of them, they don't present with, physically present with any symptoms. Okay, but they're aware of their diagnosis, they're being medicated, so and all that. So there. So the next question would be like, who do you treat in that hospital? So I usually answer this. I borrow this answer from a video I saw. I think it's a conference by the World Physiotherapy Organization, the SIG for mental health. There was a lady that said that in mental health and psychiatric settings, physical therapists usually handle 3 patients: those who have complaints unrelated to their diagnosis, those who have complaints that may be associated with their psychiatric diagnosis, and those who treat their psychiatric or mental disorders. In this setting, I don't treat the patients that because of their psych diagnosis. I usually treat them because of impairments that may or may not be related to their diagnosis, or treat them due to impairments that are totally not related to their psych diagnosis. For example, sometimes I would see patients who had a fall. They had hip surgery, then they need physical therapy, or patients who have been injured in sports, ankle sprain, and had to be immobilized, or ankle fractures, or overuse of shoulder and stuff like that. So injuries from playing some sports while they're there, and some conditions that I see them that may be related to their psych diagnosis might be chronic pain. So that's the biggest thing. Falls, probably due to their side effects of their medication. So that's really common as well. The most common side effect of antipsychotics is drug-induced Parkinsonism, or tardive dyskinesia. So that is probably one of the most interesting aspects of being a physical therapist in a psych setting, is to be on the lookout on those symptoms right away and make sure that we collaborate with the other professionals in the team then the next question will be, what is the role of the physical therapist there? As I mentioned, it's basically the same. We assess, we treat the patients, their physical impairments and disability that may be related to their mental or behavioral condition, may or may not be related. We also help, with their physical function and mobility and overall health. We develop specific plans for them, individual plans. We monitor their progress. We collaborate, as I mentioned, with other members of the healthcare team, specifically your psychiatrist, your psychologist, your primary care physicians, or nurse practitioners, your social workers, recreational therapists, um, dance therapists, art therapists, exercise therapists, occupational therapists, speech language pathologists, dietitians and nutritionists, and of course your psych techs. So this is a multimodal, multidisciplinary approach to their care. So everyone is pitching in to help these patients improve and get better. So how complex are the patients? So as I've mentioned, the most common conditions that they have are psychiatric conditions, schizophrenia, bipolar disorder, and neurocognitive disorders. They would present with maladaptive behaviors, psychosis, hallucinations, so mood, lability, uh, changes in their cognitive and mental status, again, medication side effects, and other medical comorbidities. So it's important to recognize those behaviors and uh, to be able to adapt to how the patient is presenting at a specific time of the visit. So what I usually do, when I see a patient, before I see a patient, I go to the nurses or the staff first and see how the patient is at that time. Sometimes they're okay, sometimes they're not, and when if they're not in a good place, then we reschedule. The important thing there is that they're being medicated, they're being seen by their other professionals, by the other um, members of the healthcare team, and when they're fit and they're good to be seen for their physical impairments, then I'll come in, then we'll talk. So is it challenging to treat patients in this population? I would say yes and no. For yes, because of those other factors, the psychological facts, psychiatric disorders, psychological symptoms that presents the challenge. Okay, sometimes I would encounter patients that are manipulative, patients who are malingering. So that presents that a lot of challenge there, because um, with their you want to acknowledge the patient's subjective complaints, but at the same time you also want to see if you are there, that your presence there would be beneficial for the patient. If you're there to feed on the patient's manipulation into their attention-seeking behavior, then probably you're not there as something that is good for them. But the challenge there is knowing what role and part you can do for the patient, if that is talking to them through their pain, or explain them how their condition is affecting them, then that is good. In my practice before here, I don't usually encounter patients who are malingering, patients who have something to gain to get when they get physical therapy. But here you get those kinds of patients, and you have to determine how much help you can give and how much of your time will be beneficial for you and for the patient. Um, so that is where that interest came when I started working here, and I got to dive into what is how would you determine malingering patients. It's really a hard thing to do, but you have to work closely with the other members of the healthcare team that sees the patient more often than you. So in the unit, there are patients, there are staff that stays there. They have specific nurses there, psych techs, their own psychiatrists, psychologists. So they're really closely monitored. And I'm the one that, comes in, comes out, doesn't stay in one unit, goes around the hospital. So it's important to get the input of the staff and the overall picture of the patient. Maybe in my session, the patient keeps on complaining about his back pain, and it's 10/10. But the doctor, the psych techs, the nurses would see the patient, running in the courtyard and stuff like that. So the approach would be different for those. So that's where the challenge lies. You want to be respectful to what the patient is, saying, but also seeing up to where, the benefits of your visits would be. That's where the challenge is. Sometimes no, sometimes it's not really challenging. Sometimes it's you just see a patient as you normally see in an outpatient facility. Patient comes in, tell you that there's a complaint. Patient is very agreeable in performing that treatment, doing the home exercise program, and that's it. And then you go. Easy peasy. So it varies in days, it varies in patients. So it's I think that's what's interesting in this kind of setting. What do you treat them for? Okay, so I've mentioned that I sometimes see patients due to their physical impairments that may or may not be related to their psychiatric conditions. So the referral that I get, I usually categorize them in four boxes, or four groups. First is pain. Next is weakness or limitation of motion. Third is false risk or gait instability. And last is post-op cases. Most of my patients fall under the category of pain. A lot of patients are complaining of pain. Low back pain, shoulder pain, knee pain, and hip pain is the top 3, 4 of those complaints. That is where my interest in pain neuroscience comes in now. So how are you able to educate the patient that there are multiple factors that are affecting their chronic pain? Mental health is one of them. There's stress, sleep hygiene, nutrition, and physical activity and stuff like that. So it's going inside the patient's psyche, which could affect their pain. And the challenge there is sometimes patients are amenable to those education. Sometimes they accept it, and sometimes it's hard for them to accept that they can do something about their pain. Some patients would still stick to that idea that this pain should be fixed by someone else, right? So that is what closely working with the psychiatrist and the psychologist would be helpful, to see how they can or how you all can help the patient, you know, with their, behaviors, mood, and attitude towards pain and their disability. And hopefully that, everyone, um, that helps out the patient, and see to it that, you empower the patient to take charge of their health. Um, Weakness, limitation, emotion. Sometimes you see that with older adults who don't want to do anything anymore. So primarily, that would be, uh, again, dealing with behavior. Sometimes they really don't want to do anything anymore. They just live, life through it. They eat, then they sleep, they stay in their room, and that's it. So, these patients, uh, people in this population have the capacity that they can decide on their care. They have the right to refuse um, services if they don't want to, and the only way to overturn that is through court decision. And there are certain requirements, I guess, to have that overturned. But generally, if the patient doesn't want to do anything, you can't force that patient. So next is, how do I treat the patients? Well, I treat them just like any other patient I see in any other setting. I review the referral, go to their charts, and look at the notes of the doctor, the notes of the other disciplines, see the history, um, evaluate the patient, assess the patient, do some tests, talk to the patient about, plan of care, goals, and stuff like that. So I guess the only difference or unique about the approach here in this type of setting is that you apply, psychological principles or approaches in your evaluation and in your treatment. So we've heard before, psychologically informed physical therapy, which is a multimodal approach to the care that incorporates, behavioral strategies from the mental health realm or scene, applied into physical therapy practice. So usually, you would be applying those things. In my hospital, what our thrust is, or approach that we're promoting, is trauma-informed care. There are 6 principles, key principles of trauma-informed care: safety, trustworthiness, and transparency, peer support and collaboration, empowerment, and cultural, historical, and gender issues. So, you know, as a healthcare professional, you have to provide them a safe environment for them to, uh, open up to you. Build trust in them. Uh, be transparent with them. If you're gonna say something, do it. You have to collaborate with them, empower them to work with you, and not just you telling them what to do. You know, you collaborate them with them on in terms of goal setting. You let them choose what they want to do. So sometimes, I would offer my patients, okay, what do you want to do today? Do you want to do some balance drills, or do you want to do some strengthening drills? So stuff like that. So in collaboration, you can ask, like, what do you want to achieve for physical therapy? What is it that you want to do at the end of our therapy? Sometimes they would say that I just want to walk without, without my walker, or I want to be able to run again, or I want to be able to work out again because my shoulder's hurting and stuff like that. So you have to learn um, what their purpose is in doing that, and that's part of probably motivational interviewing. Is you try to elicit and explore the person's interest in creating change and being able to comply to you. So in trauma informed care, there's also the 3 R's of TAC. What are these 3 R's? You have, first is realizing. So realizing that realization of what trauma is, and what it is all about, and how it could affect certain people or your patient specifically. You have to also, first is realize, next is recognize. You have to recognize the signs. um Sometimes signs would be like withdrawing, or being skeptic, or untrusting. So those things, so sometimes you have to realize that, recognize those stuff, and not take it against the patient. That those things might be their coping mechanism, there that might be their behavior because of the trauma. So you really have to reach out to patients, and not like dismiss them right away because of those signs. Next is responding to the signs of trauma, to be appropriate, respond them appropriately, to be still calm, to show them that they're safe in your presence, to build trust, to collaborate with them, empower them, make them choose, and last is to resist re-traumatizing. So if you have recognized that the signs and trauma is triggered by this line of questioning, then try to avoid those line of questioning, try to move on to a different one. Sometimes you'll I encounter patient with delusions of grandeur. Sometimes they're patients who are just persevering or keep on repeating what do you call this, statements and stories. And sometimes it's just their diagnosis or their disorders. Sometimes it's their habits, their emotions. They might be they're trying to cope. So you have to recognize that, try to be firm, to redirect them, prompt them to where you want them to be at that time. Sometimes in building trust, you have to sometimes ride with their stories. I had a patient that is telling me that he is the son of God. So how do you approach that? So so you just let the patient talk about that. Sometimes I don't give in, because that might hype them up. So, and sometimes I just redirect them. So it's important to not shut them down right away. Let them speak their piece. Let them put it out there. Show concern towards them. Don't show skepticism, or dismiss them right away. Don't make faces and stuff like that. So yeah, acknowledge that the patient is a person, and again, and I guess that's the most important thing there. Recognize that they have a disorder, and you are there as their advocate, as someone who is there to help them. Yeah. So what interventions do I employ or use in this setting? So as I said, it's basically the same. know. I do, therapeutic exercises, therapeutic activities, neuro education, balance, gait training, um, manual therapy if I needed to. I rarely use modalities. Um, but the most important thing there is patient education, because you are empowering them. You are trying to teach them not to depend on you for treatment. So home exercise is a big part of treatment. If I have something that is, self stretching, self exercises, and stuff like that, then that's the primary thing that I would teach them, so that they would take hold of their health and not rely on anyone. So it's just a matter of being creative with them. Again, when you're talking to them, knowing what their reasons are, and what would make them compliant and amenable to that change. So lastly, is it safe there? Yeah. So orientation process, you would be given all the safety orientation. You'll be given, the safety training, self-defense training, how to take care of yourself while inside the hospital, and hopefully and hopefully you'll be ready to whatever is coming. Safety wise, everyone in the hospital has an alarm personal duress alarm. When you pull that, it sets out an alarm by itself to make noise, and also signals the control center that you are in an incident, and they would announce your presence, that your location to everyone. So anyone who is near you would approach you. So it has a GPS, it knows your location. So anyone who is near you would rush towards you and make sure that you're safe. Okay. At the same time, there is also security inside the hospital. There are roaming, going around. Security is all, roaming around. There are security close to the unit, so that in case of, incidents like that, then they could come in and help out. I Fortunately, in my 2 years there, I haven't been in a situation like that, but in my stay then, I've uh, heard of, staff being attacked, punched, kicked, round by their wheelchairs, bitten, and stuff like that. So it's whenever I hear those stories, it brings me back that yes, I am working in this type of situation where patients can do that, or things like that may happen. So it keeps your guard up and be more vigilant of your surroundings. Like, do not put your back, do not face away from the door, because you don't know who's behind you. Don't back yourself up in a corner. Don't lock yourself in with a patient. Make sure that someone knows you're there. If if you need security, then make sure that someone is with you. So stuff like that. So it can be dangerous, but there are safety measures in place, and hopefully that those things would not be happen to anyone. Yeah, but again, we're talking about the human mind, and it can go in different places. So yeah, but everyone's looking after each other. Um, I personally I feel safe going around the units. But yeah, but hearing about those incidents that happen with other staff, it brings you back to reality that you're working in a um, complex hospital. All right, so I hope that gave you some insight, a glimpse of what working in a um, forensic psychiatric hospital is like. It's for me, it's exciting. It's it's interesting to see different behaviors and moods. It keeps you on your toes. Um, sometimes it's easy, sometimes it's not. Sometimes it's rewarding because there are patients there that would say to me that, you know what, you're the first person I talked to here that really explained to me what I could be feeling. So stuff like that. I mean, because we are, not to this other profession, but we are in a good place to sit down with patients to talk to them out about their condition, even if that is the only treatment that you're gonna provide for that day. That is, that is skilled because you're the one talking about it. You're specifying what the patient is feeling, experiencing, and sometimes, with their psychiatric diagnosis, they're very fearful of what they're doing. They are afraid of what's gonna happen to them. Sometimes they're anxious. They just need that reassurance, you know, that they are being acknowledged and they're being seen, they're being heard. Um, and that patient of mine was able to grasp that, there are factors that could affect his chronic pain, that the best days that he has would be that his pain is, down to a 1 or 2, and he realizes that it's not going to go away, but I can manage it. And he found out that, if he's more stressed, he doesn't eat well, or he's lacking sleep, that he noticed that his pain is more or has increased. So learning about that, learning about pain, talking about it, and realizing what affects his pain really helped him out until he was discharged from that hospital. So at least we have, a good place in the psych world, a realm, in seeing patients about their physical impairments. Okay, so there. If you're interested in hearing more about that kind of setting, my in a forensic psychiatric hospital, or you're interested to connect with me and talk about it more, just send me a private message, an email here in ptmillpodcast@gmail.com. Send me a private message in social media and we'll talk more. Okay, I hope this open our eyes and the possibility in our role in mental health and psychiatric settings, and behavioral settings as well. We're not just dealing with the physical aspect of our patient, but also their psychological and behavior. We're not just helping them move, but we're helping them change their behavior as well. All right, so catch the next episodes. It's gonna be great. I'm sure of it. You're gonna like it. Again, our social media, PTV Podcast, everything's PTV Podcast. All right, until next time. See ya.